Hello class, this is Dr. Turpin. I'm going to record part of our cancer kind of an overview. We're going to have a guest speaker on next Tuesday, and I just wanted you guys to have something that you could listen to a little bit in advance. We may not get through this whole section, but to kind of get some overviews on cancer before our guest speaker comes, I think would be good. And then that might give you guys a little bit more time to interact with her on some specific case studies that she's going to review. First off, these are kind of some of the symptoms when you think about cancer. You hear the terms benign and malignant, and this is just kind of how, when you're looking at cancer cells or tumors or things that might differentiate growths that might be cancerous, meaning malignant, or non-cancerous, which may be benign. Usually tumors that are local and in one spot are less likely to be malignant. If they're more invasive, kind of growing from one area or one area of tissue into another structure in the body, and they're more invasive, then they're malignant. Another way to look at those is, does the growth itself look cohesive, kind of all contained in one area with well-defined borders? Or is it non-cohesive, kind of irregular in shape, and doesn't really stop at the tissue border, meaning that it kind of grows in like strands and ways out from the center of it? Those are symptoms that tend to be more malignant. Benign growths are usually very short, slow to grow, whereas malignant cancers usually grow fairly rapidly, although there are a few cancers that are slow-growing cancers. Usually benign tumors will be encapsulated, meaning that they are very distinct and have a surrounding tissue that's all enclosed, whereas cancerous ones tend to, again, be reaching outside of those borders to distant sites. And because of the way those grow, they're not always easy to remove, making cancer tumors much harder to take out of the body, and benign tumors easily removed. And usually once a benign tumor is taken out, it does not reoccur. That is not the case with cancer, because there are always cancer cells that may be outside of the tumor tissue itself, and so then they replicate and continue to grow in another region, and because of the fast growth, replicate themselves in a fair amount of time to where they are recurring. These are the 7 warning signs of cancer. Changes in bowel and bladder habits, meaning either you've been very regular and now you're very constipated, or have a lot of diarrhea, or bladder, never had any problems but suddenly having trouble voiding, or difficulty getting a stream to start. If somebody develops a sore that does not heal, that is always a sign of cancer. If someone has unusual bleeding or discharge, in the case of like menstrual bleeding that's very heavy and abnormal, thickening of a lump in the breast or in some other area of the body where there shouldn't be a growth. Often those type of growths will feel hard and abnormally shaped, and will not necessarily feel tender in a lot of times. So, that's a rule of thumb with tumor growths, is how much pain are they causing. Usually if it's something painful, sometimes it tends to be more a cyst or an inflammatory type nodule, whereas lack of pain until it gets to be a very large tumor may not be evident right away if it is cancer. Some patients will develop indigestion or difficulty in swallowing, or an obvious change in a wart or a mole, or begin to have a nagging cough or hoarseness, a change in their voice sound. And these are the 7 warning signs that we teach patients to be more aware of, and particularly when they have a family history of cancer, to really pay attention to those type of signs and seek guidance from a practitioner, physician, someone to kind of evaluate further. So the main collaborative goals for cancer include trying to cure the actual cancer. The goal may not be to cure because maybe cure is not possible. And of course, cure means complete eradication of the disease and to prevent recurrence. Control, when a cure is not possible, sometimes we can control the growth or the size of the tumor for several years by providing treatments that just keep it kind of under control. Some cancers may not be cured, but may be controlled and put into remission for a period of time, and then they may re-exert themselves later, and then we do other measures again to try to put them back into control. Or the third goal for treatment of cancer is palliation, and we have used that term last semester just to talk a little bit about trying to really control the symptoms of the disease and to keep the quality of life as good as it can be. And palliation does not necessarily mean that you will slow progression. It may not be possible to slow progression, and it may not be that you can extend life at all. It's just a matter of making the quality of the time that you have left more feasible. So this is kind of just a good outline that kind of looks at, if you're trying to cure the disease, what types of things you might be going through. If you're trying to control the disease, how that might look different in terms of an algorithm. And then if you're doing palliation, different things that may be attempted there in terms of how care may be organized. So I'll let you take a look at that in more detail, and we'll talk a little bit more about some of this as we go. So the factors that determine the type of treatment are really based on the cell type of the cancer, the location and size of the tumor, and usually you will call that staging. The extent of the disease, meaning is it localized to one area or has it grown into different areas of the body, meaning metastasis. Whether the patient is in good physiological and psychological status, or if they have significant problems with other health concerns that make treatment very difficult. And or truly what the patient's expressed needs and desires for treatment are. So some patients may not have a real desire to fight the cancer because they have other medical concerns that really are more looming or problematic, or it may just not be their wish to extend their life if it's going to be a lot of pain or surgery or things involved. So it's really, you have to take all of these things into consideration as the care team is trying to come up with a treatment plan. So curative therapy, sometimes that may be surgery alone or periods of systemic therapy, meaning some type of chemotherapy that might be given at intervals. Sometimes surgery is done to make a tumor smaller before chemotherapy is given, and sometimes if the tumor is in a location that is not very easy to get to surgically, other other types of curative treatment might be done to try to shrink the tumor to a size that can then be operated on later. So you see different combinations of curative therapy. Control treatment, usually there's going to be an initial course and maintenance therapy. So in other words, they may get chemotherapy or radiation for an initial course and see how they respond. And then they may be set up on a maintenance of a repeat of that at periodic intervals over a period of time to try to maintain the gains that they've got from the treatment and then kind of keep the cancer from continual growth that gets larger and larger. So they'll be on a maintenance type treatment. And again, the main thing for palliation is relief or control of the symptoms and to maintain the highest quality of life. And palliation does not necessarily mean that a person is made a DNR. That might not even be their wish. It might just be to make their life and symptoms as bearable as possible. So surgery is the oldest form of cancer treatment. It meets a variety of goals and, pretty much attempts to remove a tumor and get as much margins around that tumor so that there's sort of a barrier of what's removed from regular good tissue, so that perhaps you prevent any regrowth of cancer again. You may do surgery just to biopsy something to make a staging determination, or remove a type of cell tissue to do pathology on it, and maybe that's done in more than one place in the body to make sure that it's uniformly one type of cancer. Sometimes surgery may be done to decrease the size of a tumor that is causing pain and pressure, or to control some hemorrhaging that's going on. Surgery might also be done to really take out the entire cancerous tumor at a primary site or at a site of metastasis. And sometimes surgery is done just for insertion of therapeutic devices like feeding tubes or like a suprapubic catheter for someone that's had bladder cancer. And sometimes we do simple surgeries that support our therapy, like having a portacath or a central catheter of some sort inserted that can be utilized for giving chemotherapy. So in terms of prevention, surgery is used to eliminate or reduce the risk of cancer in at-risk patients. And you think about what they call prophylactic removal of certain organs that are at high risk for malignancies. And one of the most common things that we hear a lot about lately is where patients have the breast cancer genes, and so they have a high likelihood of developing breast cancer, and so they go ahead and elect to have a prophylactic double mastectomy, kind of preventing the potential for cancer to develop and grow in that area. So, some of the genetic testing that we do really helps support this type of preventive type surgery that may be very good in terms of eradicating disease before it starts. In terms of cure and control, they usually like to remove only as much tissue as necessary during surgery and to really spare the normal tissue. Again, if there's smaller tumor size, and again I said earlier, clean tissue margins, meaning a rather large area of good tissue around the tumor, they also take out at the time of surgery. And then if there's not they'll often take lymph nodes in the areas where cancer is, just to see if there is cancer found in a lymph node. Then that may mean treatment